Hello, everyone. Welcome back. We have the pleasure of having Dr. Adrian Soto-Mota with us today. Adrian, thanks so much for being with us.
Thanks for having me. Happy to be here.
So today, I'd love to explore a lot of different facets of your work because it's so broad, with the one sort of overarching theme being metabolic health and metabolic research. So before we dive into the specifics, why did you decide to go into metabolic research as opposed to follow sort of more traditional medicine?
Um, well, I guess because I had already followed traditional medicine first. I was about to finish my residency, my internal medicine specialization. Internal medicine, for a historical reason, is not something that exists, for example, in the UK. Um, because in the UK, everything or most people is seen or followed up by a general practitioner. And people who, for example, take care of people at hospitals are not especially trained to do so. But that's like a UK thing, and all the other countries that more or less inherited the medical system from the UK. The countries that have a larger American influence have internal medicine, and we typically describe ourselves as pediatricians for adults. If you are younger than 18, you go to a pediatrician. If you're older than 70, you go to a geriatrician, and we're in the middle. And we are also frequently specialized in hospital care and in diagnosing things that are usually not so clear or hard to diagnose. So I also to finish my program. My original idea when I started it was to later become a neurologist. And around those years, one of my mentors who knew I have always had an interest in biochemistry and in metabolism, invited me to reconsider. And it had been a while last time I read about metabolism. I mean, because in most medical schools, and surely mine wasn't the exception, I really didn't have a course on nutrition, or I was not tested on nutrition. I mean, the closest that came to it was 2 semesters of biochemistry that have a little bit of integrated biochemistry at the end, or physiology, but not really. I was never educated on the role nutrition interventions could have on treating disease, not only on preventing them, but also in treating them. And because of this invitation, I dived again into a topic I had not seriously studied in a while, and it was clear to me that there was so much to do in that particular field. I mean, I'm not saying that there isn't in neurology, but some very basic concepts in nutrition, metabolism, and nutrition physiology, you could say, um, are so young or immature, so to speak, in comparison with other medical fields that, yeah, it's captured my interest, and I became convinced that it was a more open field to have a positive impact than neurology, and I switched gears and pursued a PhD in physiology.
Do you? I speak to a lot of brilliant people like yourself who are at the edge of metabolic science, and sometimes I don't know if I'm in an echo chamber or we really are on the sort of edge of this big paradigm shift. What do you think about that?
I mean, a paradigm shift is um, it's a big label, right? I mean, and I feel a bit in the middle because medicine, and you could say you could extend that to sciences. Let me make a small difference there. I tend to make a very clear difference between medicine and biomedical sciences. Medicine is not a science because the purpose of medicine is not to generate new knowledge. It's not to understand anything better. The purpose of medicine is to make your patient better. It doesn't matter if you don't understand how it works. It doesn't matter if you actually know what's causing their symptoms. It doesn't matter. The only thing that matters is that your patient gets better and prevents or preventing them from getting worse. So the objective of medicine is very different from the objective of biomedical sciences. And having made that distinction, one thing they do have in common is that they both medicine and biomedical sciences change very slowly. And paradigm shifts are never a revolution, are never from this paper onwards we all behave differently. Not even when it has been clear that we need to behave differently, medicine has changed like that. I don't know, take um, the pandemic. Even when some treatments have already been disproven, or even when some treatments had already been proven to be effective, medicine took a while in changing it. It was not a paradigm shift, a fork in the road. It was um, the incentives for medicine to change are very, very different and make it very, very slow. Science is not different, but perhaps because biomedical sciences are so close to medicine, they're even slower. It's On the other hand, I do believe that the amount of evidence in favor of using nutritional interventions to treat diseases, not only medications, for an entire century, and certainly due to the success of some medications, medicine became drug centric, pill centric. And I think that the amount of evidence that is not the full picture, that's not going to be enough for many chronic diseases is now overwhelming and is forcing some key players, some stakeholders to look in other directions, to look into lifestyle mostly.
Mm.
And I like to contribute with my grain of sand for that. So I don't, I want, I would, I guess what I'm trying to say is that if in 20 years not much has changed, I won't consider myself a failure. I don't want to make excuses beforehand, but I wouldn't be surprised if not much has changed or doesn't
Yeah.
change with the speed many of us would like to see.
Yeah. I think it's I can't remember who said it. It might be Karl Popper or Alfred White Northhead, but it was something to the effect of science progresses one funeral at a time.
I think the original
And
quote
in
is
this,
from Faraday. Yes, the original
yeah, oh,
quote
is
I
it
think is
okay?
from Faraday, and I think exactly that. Science progresses one funeral at a time. It doesn't necessarily change because we convince them. It changes because a new group of people with a new set of beliefs, some of them right, some of them wrong, hopefully, some of them updated, took over. And it's a bit of a grim scenario, but at the same time, I think that it's also reassuring because it reminds us that eventually things will progress, will get better. And it also reminds us that yeah, I think it's a good antidote against taking yourself too seriously.
Yeah,
Perhaps one of
exactly.
your latest contributions, one of my latest contributions to science, will be to retire and die.
Yeah, well, look, you are making a lot of contributions, so watch this space. Hopefully, it can make a large impact. But I think it's already is. Um, let's start with the let's start with your work with carnivore and the sort of IBD work. What led you into that specific field, and what were your learnings?
I mean, success stories from patients, which to be honest, I think it's the most simple, honest, and straightforward way to change medical practice. I mean, precisely because medicine is not a science, precisely because the only thing that matters is that the person in front of you gets better. There is this mantra in many hospitals, certainly in mine, saying that nobody should actually fight against success. It's it's dumb, it's stubborn to fight again what's clearly working, and it's unwise. It's dumb. If it's working, well, then just don't stop. Don't try to remove obstacles from it to continue working. And we do that all the time. We do that with sepsis patients, with critical care patients, with heart failure patients. We don't need to know why it's working. And once it's clear it's a success, well, then you try to understand it better so you can enhance it, you can generalize it to more cases, or you can, remove obstacles from it to continue benefiting people. So that particular strand of research emerged from success stories. And I think that, I mean, I will be honest, and I have been open about this in other interviews. I was very skeptical about IBD being so successful with uh, carbohydrate restriction for multiple reasons. And my bias is perhaps that I work in a reference center, and my exposure to IBD cases is perhaps biased because we tend to get the worst cases. We in my hospital we don't see many success cases of IBD. We tend to get referred the worst ones. So you could say that I am slightly biased towards thinking IBD is perhaps even worse than what it actually is in general. However, I think it's fair to say that nobody who lives with IBD thinks it's a mild thing. It's very incapacitating for everybody. So I was very skeptic, and I was actually one of my initial thoughts was maybe these success stories are from people who think they had IBD but had IBS, which is very uncomfortable but not as severe, and or not life threatening, at least in most cases. So that was my initial skepticism, and I'm happy to be proven wrong, especially when it's being proven wrong because somebody got better than I expected. So there's still lots we don't know about exactly why these people are feeling better, about exactly how much we can extrapolate these success stories to all IBD patients. We certainly need more research for that. But at the same time, it's such a consistent story that it's important to it's impossible to overlook it. It would be stubborn to overlook it, and I think that on one hand is safe enough, cheap enough, accessible enough for people to at least try it, right? I mean, it's not, and instead of your drugs, if you have to eat anyway, so why don't try if changing your diet changes your symptoms?
It makes a lot of sense, and the whole. I mean, one of my heroes, on you, a line that just said, "Repeat what works." Right. So we just went around the world and looked at all the great cities and just thought that works. Let's just put it in, his city, which was Singapore. But it feels like in medicine, there has to be this, reductionist view where we have to understand every single granular detail of how and why it works. But I mean, as you were talking about, these things that work we don't necessarily understand, epilepsy came to mind. And if I'm right, obviously you know way more than I do, but we still don't actually know the mechanism behind why ketogenic metabolic therapies and or a high level of ketones in the blood can help with epilepsy. So would you say it's like for like case with IBD where we know it works, we don't really know how it works, but we know that patients feel a lot better and it's
Yes,
significant?
I think that's a fair comparison. At the same time, I think that especially in this field, um, some people tend to assume that the mechanism of action for one disease isn't the same for other diseases. And I think that's flat wrong. We have lots of evidence that carbohydrate restriction or ketogenesis or ketosis in general may have very different mechanisms of actions for one disease than for another. And this is just an example of why we need to do more research to learn how to prescribe these interventions better. Because we shouldn't expect the same mechanism, the same regime, the same type of diet to be equally beneficial for all diseases. Sometimes this part of nutrition is perceived as if we believed that carbohydrates cause all diseases and carbohydrate restriction will cure all diseases. Well, of course not. Um, it is a powerful intervention because many, if not, I think it's fair to say most of the diseases we see today are either caused or aggravated by insulin resistance. And carbohydrate restriction is a very powerful intervention to ameliorate insulin resistance. So I think that explains why it seems to be that, oh, you can try this for almost everything. It won't necessarily be equally beneficial for everything. However, it's safe, accessible, cheap, easier than many of the things we prescribe daily. And it's safer than many of the things we prescribe daily. And exactly as you said with epilepsy, we don't need to exactly understand why. We don't know to what extent these effects depend on carbohydrate restriction or to what extent these effects depend on having ketone bodies elevated in the bloodstream. We don't need to get to that level of detail. And of course, the physiologist in me would love to get that level of detail, but I'm not naive. The research we need first is the research on how to prescribe it better. It's clinical research, not necessarily mechanistic research.
Hmm. Although the mechanism is, it is so interesting, right? And as you allude to, it's sort of it was my next question, which I feel I will still ask, which is the benefits of these low carbohydrate approaches. Some people attribute it's low carbohydrate. All the longevity crowd take it as calorie restriction. And then you have a lot of the ketone crowd that think actually, it's all ketones a signaling molecule and it's all the downstream effects of that. I actually spoke to someone last week who said a ketone fits the definition of a hormone because it does so many things. And I just thought it's such an interesting thing. What is your view, or do you think it's such a ridiculous, it's so complex to even have a view?
I mean, I need to disclose that I have actually the same mentor who invited me to reconsider my career. He would describe me as radical, especially because of the hormone example. First of all, yes. It's easier to make a case for BHB being a hormone than it is for many of the things that are definitely hormones. BHB is a natural ligand of at least two G-coupled membrane receptors. BHB changes gene expression by by modifying histones. It also regulates transcription factors. I mean, BHB, you could say that has more receptors in the cell than steroid hormones. And yes, however, my position is a bit radical because I generally believe that hormone is a concept that's no longer useful. Hormone was a concept that was useful perhaps in the earliest part of the 20th century, had some pedagogical value, but hormone is just not a very good concept anymore. We don't need to go into that, but I believe that because physiologically everything is linked, yes, perhaps it doesn't make much sense to try to categorize ketone bodies as something. And it's perhaps more efficient to constantly remind ourselves that we should expect effects of ketone bodies on almost every cell in the system. And we should expect some level of physiological adaptation in every tissue. So I think it's undeniable that ketone bodies have hormone-like functions, if you want to label it like that. And for some clinical applications, those hormone levels may be more important than others. For other clinical applications, carbohydrate restriction may be more important than the actual levels of ketone bodies. For example, the focus of my PhD was to see if we could expect the same benefits that have been observed from carbohydrate restriction in diabetes from exogenous ketosis. And the answer is no. Sure, ketone bodies lower blood glucose by themselves, but you can have very high levels of ketone bodies. Yes, your glucose improves, but not to the extent observed with carbohydrate restriction. So I think that's perhaps why I am kind of in the middle of the three different tribes you described, and I'm comfortable with ketone bodies being like hormones, but carbohydrate restriction being therapeutic. And I mean, I have a very strong position against the concept of a calorie, but that's also another debate. I think that longevity interventions likely benefit from fasting, and I think that fasting is an underrated, overlooked intervention. I use it frequently on myself and in some patients, and I think we understand better systems when we avoid categorizing too much the relevance.
I think it's a flaw of human thinking that everything's got to be siloed, right? To understand it, we've
Yes.
got to the physics in here and biology here, but it's hard to have a better alternative as opposed to just sort of accept that the world is very multidisciplinary and everything interacts with everything. So much to double.
Our brain loves an easy explanation. We are pattern recognition animals, and we are biased towards preferring the straightforward, simple answer, precisely because it allows us to sometimes, with some level of success, overlook complexity. So I think that's a perennial temptation we need to avoid in science.
Yes, okay, that makes a lot of sense. If I'm right in saying your study within the IBD, I guess when you were studying IBD, am I right in saying it was actually carnivore as opposed to strict keto?
Some of them, if I remember correctly, the majority of them, yes, it was carnivore. But some of
Okay,
them were eating, low carbohydrate some low carbohydrate vegetables.
because it's funny because a lot of the benefits of keto, I guess metabolic therapy, hardcore ketosis, you're looking for I don't know, trying to get a BHB above 2.5, whatever it is. Sometimes people get the same benefits with carnivore, but yet if you were to track their level of ketones and their glucose, it'd be very different. What do you think is going on there?
I think it's perhaps, I think it's a tough thing to answer because for some people, and actually, a while ago when discussing that set of cases, I mentioned that I wouldn't be surprised if even for the same disease, for some people is more important carbohydrate restriction than BHB levels. Whereas for the same disease is the other way around. Or for the same disease, a different mechanism is more important than another.
Mm.
And this is part also of why it is hard to do research on these things. Because when I tell a patient to restrict carbohydrates, I am changing multiple things at the same time. So sometimes it's hard to say what worked and what caused what. I'm not saying other fields or scientific fields have it easier, but this one is certainly especially complex because it's impossible to restrict carbohydrates without changing many other physiological things or many other pathophysiological things. So I think it's hard to hard and perhaps fruitless to obsess too much on on answering what exactly is going on there. At the same
Mm.
time, for example, inflammation changes glucose metabolism. Inflammation causes insulin resistance. That's one of its hallmarks. So it's also hard to dissect how these things interplay with each other, especially across time because they are changing. So I don't want to dodge the question. I just want to say that the honest answer is I don't know. And
No,
the follow up of that answer is I don't expect to know soon because it's a tough thing to answer.
no, it's a brilliant answer in itself because it highlights why these things are so hard to prove in a randomized control study. You know, it's a complex adaptive system, open complex adaptive system with so many variables and so much going on. To pinpoint and isolate one variable is in itself, like as you say, it's a fruitless
Yeah.
exercise. And so you got to come at it with that humility, which is it's a nice point. Uh, I have to double click on the hormone comment and the calorie comment because I'd be remiss if I didn't. So, what is flawed with our understanding of hormones as hormones?
The textbook's definition for a hormone is a substance that's produced or stored in a tissue that acts in another. So, and this is, I mean, Boron's Physiology, my favorite physiology book. It's a substance that's produced in one place and acts in another. This is already problematic because should we consider neurotransmitters a hormone? They are produced in one part and acting in another, and then you could say, well, no, because it's two contiguous cells, so maybe no. Okay, but is there in calcium a hormone? Because it's stored in the bones and acts in the kidney, for example. Is CO2 a hormone? Because it's produced in the skeletal muscles and acts in your central nervous system. It suddenly appears that everything can be a hormone. And when you face a concept that with a definition that can be met by almost anything, well, then you should question if it's a useful concept. Because what would be the difference between CO2 being produced in your skeletal muscle and acting in your central nervous system? Are we going to call it a hormone now? Should we call the endocrinologist when a patient is not breathing properly and accumulating CO2? The other way around, I mean, we do call endocrinologists for calcium disorders, but when cancer, for example, when some tumors have abnormal calcium disorders, do we, because medicine is siloed, we built these borders between these imaginary borders in a system. What about glucose, for example? Glucose can be produced in your liver, can be produced in your kidneys, and can be exported to other tissues and change cellular behavior in those other tissues. Should we start calling glucose a hormone? So if everything
Yeah,
is a hormone, well, then nothing is a hormone. And it
that's
was a
such.
concept that was useful perhaps some time ago, but in my mind, endocrinology is nested within physiology. And we've already started getting to the point where this nest stops making sense. And it's physiology. That's it.
Mm, yeah, I mean, I'm trying to think of anything that does one thing in the human body, but I'm struggling. So yeah, it makes a lot of sense to me. Okay, and then you said you had a comment about calories. Let's go there because also I would be remiss if I didn't ask.
I mean, I am part of my research has touched this debate between the carbohydrate insulin model and what later became known as the energy based model. And because some of my papers have a clear, strong position in favor of one and against the other, perhaps my opinion is biased. But I think, of course, calories are a thing, right? I mean, of course, they are physically a useful concept in physics. There's no question about that. What I tend to question is their utility in biology. And what I would absolutely oppose is their utility in clinical practice for multiple reasons. First of all, this idea of the adipose tissue keeping track of how many calories arrived, and from that input deciding how much fat to store, is hard to fathom biologically because, where is the receptor for calories? Where is the organelle or the enzyme that allows the adipocytes to keep track on, okay, this amount of calories arrived? Because also it doesn't see calories, right? I mean, it sees amount of fat, amount of protein, amount of carbohydrates that arrived. So when does it make a conversion, right? Where in the adipocyte occurs this conversion between this is 2 grams of carbohydrates, therefore I will count this as an 8 in calories, and from that input change its behavior on how much fat to store. At the same time, I think that energy balance, part of this debate occurs because energy balance is tautological in biological systems. In the end, things will be balanced for sure. I mean, I also don't deny that one of the governing laws of nature is that energy must be balanced. The discrepancy is in not only weight changes, adiposity changes occurring as a consequence of that energy balance. I think that first there was a different stimuli in nutrition, a different nutritional stimuli, which changed physiology, which changed fat deposition, and sure, in the end of it, everything was balanced. But at the same time, and this is different from assuming that there was an imbalance in energy that changed physiology, which changed fats deposition. So I think you could also argue that it is perhaps a semantic debate. It is a rabbit hole in its own. I do believe that part of the mistake comes from the fact that equations and formulas look very much alike. And when people hear that, oh, the first law of thermodynamics and everything must be balanced, well, sure. But it's very different to say that the amount of energy you eat and the amount of energy you spend compute energy balance than cause energy balance. An equation is a statement about the equality of two expressions, the mathematical equality of two expressions. A formula is not. A formula is a causal statement. So I think that some people have confused an equivalency statement with a causal statement. And in practical purposes, this is detrimental because it's very hard to keep track of calories. Even if you want to do it, as rigorously as possible, the energy content declarations in most countries have a very large allowed margin. So your margin of error is super large, is not clinically practical. And at the same time, I think it shifts attention to more efficient points in someone's nutrition. It shifts attention to the quality of things you are eating and the effect they have in your body. So I think that calories are sometimes misleading, and I haven't seen they help many of my patients. Most of my patients prefer to focus on quality and quantity of carbohydrates than net amount of calories. And so clinically speaking, I don't think they are terribly useful. Biologically speaking, I think they are hard to defend concept, because it's also a saying, oh, why am I poor? Well, because you are spending more money than what you earn. That's terribly informative, right? I mean, sure, that's true. That's if you didn't spend more money on what you earned, then progressively, the statement, it's not incorrect.
Mm.
What's incorrect is that the statement is not especially informative about what's going on.
Yeah, it's such a small thing and such a complex system. The line I've always had an issue with, which was exactly as you said, people saying, "Oh, it's the law of thermodynamics." It's like, yeah, but you're telling, you'd have to be a genius to know that 1,000 calories of broccoli is going to interact very differently to 1,000 calories of MCT oil versus McDonald's versus whatever, and it falls apart. It's not clear.
It also assumes that efficiency of absorption is the same for all those foods, and that that all of them are absorbed equally. And it also assumes that efficiency of consumption is the same for all those foods, which is also context dependent. So I think it's an oversimplification of a biological reality that eventually became a causal statement about why people change weight or change adiposity. The adipose tissue is far from being a storage room where it's much more than that. So I think it's an oversimplified understanding of why adiposity changes, and I believe that now we know enough physiology to have a clearer, but more importantly, a clinically useful picture of how to change weight in people who wants to.
Wonderful. Well, I mean, lots of different ways to do that. I mean, the keto being one, which sort of segues us into the, your keto CTA paper. Well, I guess study, I should say. So, the keto CTA study suggests LDL and ApoB might not predict heart disease in keto adapted people. If I've got that right, what should we make of this?
I would make I would modify that statement. I think that it suggests that elevated ApoB or elevated LDL, LDLC to be more precise, is not predictive of plaque changes among people who have an LMHR phenotype, because you can have that phenotype. Sorry, let me rephrase. Because not all keto adapted people have that phenotype. That's the distinction I would draw. Not everybody who is already well adapted to a ketogenic diet has that phenotype. And I would also emphasize that that phenotype is rare, is not the majority of people restricting carbohydrates, mostly because almost everybody in today's world have at least some degree of insulin resistance. There is this paper from a group in North Carolina that documented that 88% of North Americans have at least one marker of metabolic syndrome. In my home country, that number is not 88, it's 91. So there are lots of people with at least one marker of insulin resistance. Therefore, it should be no surprise that this is already rare. Now, we know that there is a very different lipid behavior in people who start carbohydrate restriction with overweight or obesity than those who start carbohydrate restriction and are lean. And the other point I would emphasize there is that someone's lipid panel phenotype tells me nothing about their blood pressure, for example, because you can have an elementary phenotype with high blood pressure. You can have an elementary phenotype and smoke. You can have that elementary phenotype and have have chronic inflammation. So, you know, being or trying to not fall in the same reductionism we frequently criticize, we shouldn't think that the elementary phenotype is enough to say someone is metabolically healthy or keto adapted. The elementary phenotype is just a lipid phenotype, frequently associated with being metabolically healthy, but simply because you need to be, or it's very likely you need to be insulin sensitive to develop it. But it's not enough to say someone is healthy. It's not a marker of someone's health. And
Okay.
in this subset of people, then yes, it looks from the data we collected and analyzed that the association we observe in many other people between ApoB and plaque changes is different in these people, is flat. There is no association in people who meet this phenotype. This doesn't
I
mean
mean,
they
they
don't
say,
have plaque progression. It means that plaque progression is not explained by their high ApoB.
okay, right. So it's more an extreme case that educates better than the norm, as
Yeah.
opposed to it's they're fine, they don't worry at all. Okay, and so just for the listener, so lean mass hyper-responder is what we're referring to there. The people who, if I'm going to butcher this probably, but I'll give it a go, who, if they're keto, been on a low carbohydrate diet or a keto diet for a while, their LDL rises when they're keto adapted. Is that right?
Yes, but it's not the only change. That's what takes most people's attention. But the elementary phenotype has simultaneously high LDL, high HDL, and low triglycerides. So if it's just high LDL, well, then that's not an elementary phenotype. You need to have all three.
Okay. Okay. And through that whole study, what surprised you the most?
My initial hypothesis was that there was going to be a signal among those with high baseline cardiovascular risk. I mean, I thought that perhaps, my hypothesis was that low risk people, it was very likely there wasn't going to be an association, but I did expect to see some association in high risk people. So I was surprised there was none. And we in our sensitivity analysis, we looked in many different ways at those data. And we did everything we could to set up the ground for that signal to emerge, and we didn't see it. So that was a surprise for me. I was expecting
Mm.
a set of results, of mixed results, not for some, yes for others.
Okay, and around the conversation on sort of statins and lipids, how does this paper, if at all, change that conversation?
I mean, I don't want to throw shade in our own paper, but I will say that it changes that conversation very little. Because we've known for a while how to assess the risk benefit ratio of someone taking a statin with other tools, and regardless of their elemental phenotype status, you could say. So we know, for example, that the number needed to treat with a statin to prevent one major cardiovascular event in people who have had a major cardiovascular event, who are by far the highest risk category, There's nothing more predictive of a cardiovascular event than having already had a cardiovascular event. So, so that's the difference between primary prevention and secondary prevention. Primary prevention is you've never had it in your life. We want to prevent the first one. Secondary prevention, you already have a stroke or, uh, a heart attack, a myocardial infarction, and we want to prevent the next one. So the number needed to treat with statins for secondary prevention is 50, which is very different from the number needed to treat in primary prevention for people with low cardiovascular risk. For people who have a 10-year cardiovascular risk below 5%, the number needed to treat is not 50, it's 450. So you have a 9-fold difference in this ratio, in this risk-benefit ratio. And this is important because since these people are metabolically healthy, their blood pressure is normal, they don't have diabetes, none of them were current smokers. Some of them smoked before, but not anymore. You could say that they are more likely to be in the low risk category. Actually, guidelines now support that people who have CAC, a coronary artery calcium score of 0, and don't have other, super clear risk factors can avoid the statin, can be, simply remain in follow-up. And more than half of those patients have a CAC of 0. So I think that, this paper won't necessarily, or I wouldn't expect it to change statin guidelines because it's, if anything, confirming something we already knew. Some people have CAC of 0, but have high or medium cardiovascular risk. Most people with CAC of 0 have low cardiovascular risk. And even if our paper didn't exist, guidelines would support not treating with statins many of those patients. Perhaps the point of disagreement is that guidelines, some guidelines suggest that people with very high LDL, that's an automatic pass for a statin. And some other guidelines say, okay, very high LDL deserves follow-up, but not automatically a statin. If everything else is okay, then just follow up. Well, that's exactly what we've been saying, right? If you have an LMH phenotype, follow it up. Remember, you should be mindful of your blood pressure. You should be mindful of your inflammation status. You should be mindful of your sleep pattern, hygiene. Follow it up. If you are one of those LMHRs who has no CAC or very low CAC, and you don't want to take a statin, well, consider following it up.
Okay, that's super clear. I know you've studied the effect of ketones on the brain as well, and our audience is very interested in sort of the different effects ketones can have on the brain. What are the sort of what are you most excited about when it comes to the brain? And could be low carbohydrate, could be metabolic therapies, could be exogenous ketones, but that sort of field on itself.
I think that, I'm biased because, as we discussed minutes ago, I wanted to be a neurologist, so the brain has always excited me a lot. I've always thought it's the most fascinating organ we have. Not to throw shade on kidneys or the liver, every cell is fantastic, but the brain is something else. So I think that what excites me the most is this set of evidence that forces us to remember that the brain is an incredibly expensive, in metabolic terms, organ, and therefore metabolic disarrangements will have neurological consequences. And I think that one of the things I usually say to make this more intuitive, when people hear for the first time about, for example, metabolic psychiatry, is that, well, if you take into account that our brain is especially expensive, think in a hypoglycemia. People who live with diabetes and are injecting insulin have the risk of developing hypoglycememia. Well, you can see the brain effects of low energy status within seconds. When your glucose starts going down, the brain immediately complains of not having enough energy. And it's quite dramatic about it. So I think that we have a very stubborn, very energy demanding organ. We shouldn't be surprised that if your energy delivery system is broken, something is going to happen with that organ. So there will be some manifestations. And I think it's especially exciting, all the research that's going on the psychiatric manifestations of deranged metabolism. There is this very cool paper published little more than a year ago in JAMA Psychiatry, where with data analysis they basically built how deranged is a system. So in patients living with depression, bipolar, schizophrenia, and generalized anxiety disorder, they built these radar plots on which is the system in this set of patients that's further from what healthy looks like. And they have, cardiovascular, lungs, they have brain imaging. And by far, in all cases, the most far from normal system was metabolism. So I think that it's very exciting, this new set of evidence that forces everybody to remember that a metabolically expensive organ will have clinical manifestations, will develop disease if the energy delivery system is broken.
Okay, so being an ambitious person like you are, and being someone who wanted to be a neurologist, but coupled with someone who has, you're doing a lot of this research, you're in the field. How do you then, on a day-to-day basis, go about making sure your brain is at its best from a metabolic point of view?
Well, I do multiple things. My lifestyle was not healthy for still the most part of my life. So as many kids in Mexico, I was a fat one, and my brain developed with surrounded by ultra processed foods, Coca Colas, sweets. So I still notice how I have. I usually say the brain of a fat kid in my body. So I don't expect that to change. I avoid lots of foods that were common in my routine for many years. I am increasingly jealous about my sleep patterns and about my sleep hygiene. I certainly don't love the idea of jumping into a plane in a few hours and change 7 time zones within the same day, and arriving at in the middle of the day when. So I think sleep is another hugely overlooked area that can cause and treat disease. And I think that I avoid caffeine after 2 p.m., 3 p.m. maximum. I and I take multiple steps to improving my sleep quality as much as I can. Uh, the temperature in the room where I sleep is controlled. I if whenever I can, I avoid staying up late. And sure, I do believe that restricting sugar, restricting ultra processed foods helps me protect my brain, or at least stop harming it with the exposures I used to do. I don't. I have never smoked, and I try to keep my brain busy with work and other stimulating things. But I think that it's. I mean, nutrition is only a part of a whole routine that prevents health disease and or promotes health disease, we should say. Sorry, promotes
Yeah.
health, brain health. Sure, it's a very important part, but you can have a very good diet and very poor sleep hygiene, and you would still see the results, I'm sure.
Yes, yes. We had Dr. Tommy Wood on the podcast a while ago, neurologist and brilliant guy,
Yeah,
and
no,
he said,
I know Tommy. He's great.
you. Okay, great. I think his point was, someone with a perfect diet who's completely sedentary all day long, you're not going to see any sort of cognitive benefit there. And then the same, right? With exercise, it can't out exercise a really poor diet. Do you take
Absolutely.
exogenous keto?
I mean, from time to time I do, not for health uh, reasons or performance reasons. Something that I think is that exogenous ketones, all form of supplements, really, will work wonders on those who have uh, deficiency that can be addressed by that supplementation. If you have iron deficiency and supplement iron, well, sure, lots of things will improve. But if you have, no problems with iron, you don't have anemia, your red blood cells are happy, taking extra iron is unlikely to have tangible benefits in your routine. So I am
Mm.
fortunate enough to have enjoyed uh, good brain routine for multiple years now. And in other words, I mean, I don't think exogenous ketones will give you superpowers. If there is something that you know could be better in with your brain energy, sure, I'm sure they can be super helpful. Um, I don't know, for example, there has been multiple reported cases in which people with different forms of cognitive decline improved with exogenous ketones. Perhaps the most famous one, or the first one I heard of, is from Mary Newport. So we know
Mm.
that if there's something not going on well, sure, an exogenous ketone can be very, very helpful. But if everything is going well, then not necessarily. It's not given that you will see, you know, enhanced functionality. And
Mm.
I believe that for someone who wants to make a pattern in brain health promotion, supplements play a role if and only if there's something to be fixed.
Yes, I think it's a really interesting point as well. And, extrapolate that deficiency up to baseline. Well, if we just keep going, it will be something non-linear where it doesn't quite work like that,
They,
right?
they, they can
It's
bring you back to baseline. Actually, in one of the experiments with my PhD, we saw this with cardiac function. We were measuring intramyocardial levels of ATP, and it had been observed previously, well, before and after exogenous ketone administration, it had been observed previously that those who had low levels of ATP, these levels were restored when you give an exogenous ketone. But when we tested this in healthy subjects, there was no change. They simply remained at baseline.
okay. Yeah. No, it's a good point to highlight for sure. I'm definitely guilty of, thinking, oh, great, if I just take more of something, it'll be more beneficial, but it doesn't quite work like that, right? Okay, we'll just end with some quick fire questions, if we may.
Sure.
You got a super sharp mind and a really interesting worldview. I'd love to know if there's any books you've read that have helped shaped, how you see the world. They don't have to be health related; it could be anything.
Oh, there are many. Um, for sure there are many.
I mean, for the audio listener, there's a big bookcase behind uh, Dr. Soto-Mota's screen right now, so it was an easy question.
Yes. I think especially one of the teachers who has influenced the most in my thinking. Um, he was a visiting professor at Oxford when I met him. I met him during my PhD. His name is Alan Garfinkel, and he's a professor of math at UCLA, and he has a fantastic book um, titled "Modeling Life," which is about yeah, mathematical models for biological systems. So, um, in more than one way, my uh, way of analyzing physiology is heavily influenced by his work in that book. Um,
Mm.
Another book I would consider also technical, I should say, is Rethinking Statistics from Richard McElrath. Uh, he's actually an anthropologist, and has a very good book. It did change the way I saw statistical inference. Um, Another fantastic book I would definitely recommend. One of my favorite books from the last 2 or 3 years is Aubrey Clayton's Bernoulli's Fallacy. That was another great recommendation. My favorite book of human metabolism, even though we may disagree specifically on the concept of calories, is Keith Frains and Rhys Evans' Human Metabolism. Rhys Evans was one of my PhD tutors, and the latest edition is the fourth edition of their book, and the first three editions were written solely by Keith Frain, and the fourth edition was co-written by Rhys, and that also definitely I would say that's perhaps the book that convinced me to go into metabolism. When I was in my residency years, and I said, okay, I'm gonna re-educate myself in human metabolism and nutrition physiology. I looked for books, and back then there was only three editions, and I only found three books, but were really the three editions of the same book. So so I read that book cover to cover twice, and yeah, I could blame that book for changing uh, my career and for re-educating me. There are some things in the book I think need to be updated, but that's also a good testament of that book. And those books are, I think, very informative for understanding better physiology and human metabolism and data analysis.
Mm. Well, I'm definitely going to order the last one. I feel like I'd like to have a sort of bottoms up approach of actually understanding the metabolism. Um, I speak to brilliant people like yourself, but I think I need to sort of go back and build the sort of foundations on top of it a little bit. Um, Last question from me is: what is one thing you believe is true that most people disagree with you on? I mean, I know you've had a few with the hormones and the calories, but you strike me as someone who'd be interesting to ask anyway. So,
Um, okay. Also very big and controversial topic, but you asked for it. I I believe that algebra is not math, that it's symbol manipulation, and that true math is almost exclusively geometrical, and that algebra was an incredibly powerful tool that allowed us to solve some tough to crack problems some centuries ago, but it came at the cost of sometimes forgetting the true geometrical, non-algebraic, and not necessarily digital nature of math. I think math doesn't require not even the concept of a number, but math is definitely geometrical, and I think that the best way to teach someone calculus is ditching as much as necessary algebra to make room for geometrical examples. And if I may add another, this is stolen from Richard McElrath. I believe that our best tool for understanding reality is a simulation. And Richard McElrath typically phrases that as reality is a simulation. And of course, there's a double intent in that statement, but I believe it's true. I believe that it's counterintuitive for many. Our best tool for understanding reality is a simulation.
Why is it the best tool?
Because it's the only way we can control the sources of influence and then compare if that matches to what we observe. So it's only when we are aware of all sources of influence that we can start dissecting if there's additional ones we haven't thought of. So I believe that computers now that make that easy, and the best telescope into reality is a computer simulation.
Okay. Well, I mean, everything is a rough approximation of reality, right? And
I also agree with that. But I do believe that more and more people agree with that our perception of reality is a misrepresentation of physical reality. However, I believe more people subscribe to that, at least in STEM or in biological sciences. Some people still struggle or dislike the idea of simulating data.
Okay. Well, look, you're a fascinating man. Could talk to you about all sorts all day. Ketogenic metabolic therapies, back to simulations, back to, everything in between. So it's been a real pleasure for me and super fun to sit down and chat. So thank you. Well, really, really had a great time. Where can we keep up with your work, follow along with your papers? Where can we find you?
I'm not great with social media. Perhaps the place I visit the most is Twitter, or X, and Adrian Soto-Mota. But I'm not as active as I was. But I think when I make threads or explanations about my papers, they're usually there.
Okay, awesome. We'll put all the links, everything we discussed, the books, X profile in the show notes. And yeah, Dr. Soto-Mota, thank you so much for coming on.
Thank you.